So following that patient's journey, I guess the orthopedic surgery team has had their crack at it a couple of times, patients being discussed at the multidisciplinary conference, and the decision collectively is that we need to do something other than surgery. So let me invite Dr. Bob Mackey to sort of walk us through what molecular genetic testing would you order, Bob? And can you walk us through the rationale for the CSF1 receptor inhibition?
The more you look, the more you find. And we haven't always had the great molecular genetic tools that we now have access to. Happily, at least for this diagnosis of tenosynovial giant cell tumor, you really don't need those. Our pathologists with simple immunohistochemistry can generally identify these. But on a research basis, at least, we're understanding more about these tumors. And what at first glance looked like something pretty simple may actually end up being a bit more complicated. Although at the end of the day, CSF1 receptor blockade is the answer to these problems. The initial work was done basically about 10 years ago. First paper came out from Stanford, from Matt Vanderen and colleagues there, who showed that there was a translocation between chromosomes 1 and 2, which led to activation and production of CSF1 in these tumors. But it turned out that when you have lots of CSF1 around, it is not just causing growth of the tumor on an autocrine basis. It's basically serving as a signal beacon for other cells to come into that area. And you get a strong pro-inflammatory response by the nature of having a lot of CSF1 around. So it may be both trophic, allowing the tumor cells to grow themselves, but it also brings in a very brisk lymphocytic infiltrate and then secondary cytokines that arise from that. There's some new work showing that there's some different translocations that can be involved in these tumors. And also it's not entirely clear that it's the collagen gene that's driving this. It may be some other reasons for having extra CSF1 around, in some recent work by Liz D'Amico, Torsten Nielsen and colleagues. But by and large, at the end of the day, you got more CSF1 around, and that's what's driving the tumor growth, and certainly a lot of the symptoms of this tumor.
Very good. So that's a wonderful hypothesis, and then that leads to a hypothesis-driven research. I think ever since we've known about the CSF1 receptor overexpression, we've used the weaker agents that we've had available to us to try to treat these patients, and we'll come back to that a little bit later. But clearly, a more potent, a more specific CSF1 receptor inhibitor was approved by the FDA for the treatment of patients with symptomatic and advanced tenosynovial giant cell tumor. So let me see if Dr. D'Amato can walk us through the FDA approval, the trial design, and some of the evidence supporting the use of pexidartinib in patients who do require systemic therapy. Gina?
Again, pexidartinib was FDA approved, and this was based on what we call the ENLIVEN clinical trial, which was a multi-center randomized double-blind placebo-controlled phase 3 study. And patients had to have symptomatic TGCT, and which we used to call PVNS, or pigmented villonodular synovitis. Now we've changed it over to TGCT, and these patients were deemed not a surgical candidate. And so patients were randomized in a one-to-one fashion. They were given Turalio 400 milligrams in the morning and 600 milligrams in the evening, and then 400 milligrams twice daily. And so that was based on the initial part 1, and then the part 2 part was just the 400 milligrams twice daily. And the primary endpoint was overall response rate was the primary endpoint. And using RECIST criteria, and the secondary endpoints were overall response rate by tumor volume score, mean change from baseline, range of motion, and duration of response. And the patients were, the majority of patients, as Dr. Lee and Abraham discussed, the majority of these patients do have knee as their primary location. That was 61% with ankle, and the 18% did have a foot and wrist. The majority did not have prior systemic therapy, although 9% did. And some actually was split, whether some patients had prior surgery where others did not, and the majority were diffuse, as we talked about. And the overall response rate by RECIST criteria was 38% versus 0% in the placebo, with a 15% complete response, which is really astounding. About 80% of these patients were on it for more than 6 months, and 2/3 were on it for over a year. And then we looked also at tumor volume, which is difficult to measure by RECIST criteria. As we know, RECIST criteria is the sum of the longest diameters, but these aren't always perfectly round tumors. They have that's the name diffuse, so it's hard to measure. So if you look at tumor volume, that's a little bit better way to actually measure that. And by tumor volume, the response rate was 56%. So that's very impressive as well. There was also significantly improved range of motion compared to the placebo, and so that's the efficacy data.
I think this is an important summary, right? So I think the response rates were good. The tumor volume reduction was good. I think this brings up the difficulties of RECIST response rates in oncology in general. And I think at the end of the day, what matters to the patient, obviously, is symptom control, improvement in range of motion, decreased stiffness, the PROMIS scores, if you will. So I think the trial does indeed show some broad range of benefits that these patients experience, which was obviously the reason why the drug got approved.